distinguished speakers, and learned friends. It's a privilege to be standing here and being able to discuss with you the topic, reforming medical education to benefit masses. Now, the purpose of this talk is twofold. First is to discuss the innovative strategies and emerging trends in medical education which have been adopted by the educators all around the world successfully. And the second is to highlight the implications and importance of these need-based reforms in medical training. Now, through this slide, I just want to focus that the primary aim of our medical education is to benefit the ultimate recipients, that is our patients. Now, here the slide shows the number of medical colleges located across the country. Dr. Shakti Gupta has clearly given us the statistics. We still need so many new medical colleges. Moreover, the concentration of the medical colleges is more in the southern and the western zones of our country. The central zone having only 3 to 5% of the medical colleges, and the northeast zone having only 5% of the medical colleges. Now, in the education reform cycle, depending upon the population health needs, we need to define the learning objectives, understand the pitfalls of the current curriculum, design a new curriculum, and plan on implementing it. We need to implement it and then evaluate whether it has been successful or not. And we need to again look into the population health needs and review whether our program was successful or not. So the reform strategies need to be undertaken at 3 different levels: the curriculum level, the infrastructure levels, and a community service program level. Now, most of us know about the traditional medical curriculum, even the non-medical people here. We have a 4.5 years of traditional medical curriculum in which we have intensive lectures followed by a clinical training. By the time a student goes from the basic sciences or the paraclinical sciences to the clinical sciences, he forgets what he has learned in the first 1.5 or 2 years. He does not have the time to go back and study what he's forgotten. Now, this slide here clearly shows the difference between the pedagogy and the andragogy. In andragogy, through his own self-interest, observation and interpretation, a student is able to learn better. He can do self-appraisal, he can get validation from the peers, as well as grades from the text and the teachers. So this is a better way of seeking knowledge, undergoing critical analysis of things, and understanding the subject matter in a better way. So as we progress further, we need to shift from the traditional medical curriculum to the SPICES model, which is student-centered, problem-based, integrated, community-based, with electives and a more systematic method of teaching learning. Now, the strategic initiatives that need to be put in to enhance teaching learning are integrated teaching, shifting focus from didactic lectures to small group teaching, which is more interactive. We need to put in self-directed learning by ways of methodologies like problem-based learning. We need to introduce skill labs, simulation studies, and alongside we also need to put in many more faculty development programs at regular intervals. Regarding assessment also, we need to make the long questions obsolete. They are still being followed in so many of our medical colleges. We need to make them totally obsolete, and we need to focus on structured short answer questions and multiple choice questions through which we'll be able to assess an in-depth knowledge of the student regarding the subject matter. Regarding the practicals and clinicals also, we need to make our assessment based on OSPI and OSCE, that is objective structured practical examination and objective structured clinical assessment. Alongside, we also need to evaluate all the 3 domains: not just the cognitive and the psychomotor domains, but also the affective domain. In addition, we need to put in or reinforce topics like feedback and humanities. Feedback not merely of the students by way of assessment, but also of the faculty members. There are so many new medical colleges, private colleges as well. And we as medical students graduate from our MBBS course, we undergo PG training, and we immediately become teachers. But are we good teachers? Are we able to deliver the content properly to our students? So we need to have a regular feedback from the students, and we need to constantly improve ourselves. Humanity is another hit area where we need to focus. Bioethics, professionalism are all areas which are not emphasized in the current medical curriculum. Dr. Shakti Gupta has also talked about the medical integration program. Now, this medical integration is a must in the coming reform sessions. We need to undertake all types of medical integration, be it intra-departmental, horizontal, or vertical. Now, problem-based learning is another methodology which is being followed very popularly in the Western countries. Now, this is a trigger-based study method, a small group teaching method in which a small trigger is given to a small group of students. The students see that trigger, they go back, find out ways of learning or knowing more about that trigger, they identify learning issues, they come back, discuss it, plan an inquiry, again talk with the facilitator, talk amongst themselves, and then again go back, reformulate the program, and in the next session they come back and reach diagnostic decisions. Now, another tool that has been used in medical education is simulation. The simulators are instructional processes which substitute real patient encounters with artificial models, live actors, and virtual reality patients. Now, in medical profession, we deal with patients. We cannot use them as practice targets. We cannot, what we say, haath saaf karna on the patients. We need to have some simulators so that when we approach the patient for suturing or for some other procedure, we are confident enough that we'll do it right. The advantages of simulations we are all aware of. It clearly connects the course and the clinical objectives. It avoids the pitfalls of unplanned events, allows reflection and establishes learner outcomes, and allows learning in a safe, responsive environment. Another benefit is it can be reused repeatedly and tailored to specific instructional objectives. The different types of simulations that are currently used are standardized patients, partial task trainers, mannequins, screen-based computer simulators, and virtual reality simulators. Now, regarding assessment, let me say a few lines on OSCE, or Objective Structured Clinical Examination. Now, this is an assessment method in which many circuits, many stations are created, many procedural stations are created. The students have to pass through each test station, perform a standardized task in the presence of an examiner or an observer. That examiner or an observer has a structured rating form. For example, when we ask a student to see whether the patient is having hepatomegaly or not, he immediately goes to the patient, removes the clothes, uncovers the abdomen, and immediately insinuates his fingers in the right hypochondrium and comes back with a report. Yes, sir, 3 fingers, tender hepatomegaly. We have not checked whether the student informed the patient that, yes, I am going to examine your abdomen. Can I? I will not give you any harm. Did he rub his hands or not? Did he do it gently or was he rough? And finally, did he say thank you? So these are areas where we are lacking, and this OSCE pattern of examination helps us in evaluating all these things. So in assessment also, we not only want to assess whether the student knows or not, we want to know whether he knows how to do it, he can show how to do it, and whether he'll be able to do it in future or not. Now, the proposed GME by the Medical Council of India has tried to incorporate a few of these things. A foundation course has been introduced, a 2-month foundation course has been introduced, in which a student will be able to orient himself to the medical curricula. And one other important thing is, it will help him or her in understanding the language of instruction. Now, in current setup, an All India entrance test is there, so a student from Kolkata might be able to go to the southern zone and do his medical studies. He may not initially be able to understand the accent, the dialect of, even if it is English, he will not be able to understand it in a proper way. It will be better for him if he starts learning the regional accent and the regional dialect. So he has 2 months of time in which to orient himself to the language and a few more skills which are required for the medical curriculum. Even computer training as well. Along with this, another reform that has been introduced is the NEET which has been kept here, the entrance test which has been kept at the beginning of internship. Now, currently what is happening is the students finish their 4.5 years curriculum, then they have to do a 1-year internship course followed by the entrance test, the PG entrance test. But what are the students doing these days? They skip their internship postings and they just bunk their postings and they go and study for the PG entrance tests, which are more important for them. So the MCI has proposed that this entrance test should be kept at the beginning of the internship so that the student is able to focus on his internship and learn the procedural skills. Besides this, as is evident in this slide, ethics has been included in each phase of the MBBS course. Now this is where the doctors today are definitely lacking. Humanities need to be emphasized. Besides this, self-directed learning hours have been included in the orientation course as well as in each curriculum, in each subject curriculum. This is to enable the students to develop critical thinking of the subject matter. Now we can plan strategies, we can execute them. We have to wait for the results. Again, we need to review and go back and plan again if needed. Some challenges will remain. How can we do better? How are we doing and how can we do better? What is the best balance between generalists and specialists? How many years program do we actually need to educate the doctors to the maximum? And more importantly, with the advent of so many private medical colleges, we need to know who are we taking into our medical schools? Are the students coming by self-motivation or is it some carrot dangling in front of them for which they are entering the medical profession? Thank you.
Well said.